and welcome everybody to our October monthly WebEx series, where the focus really is specifically on omitted medicines. So it's great to have everybody along, and I would like to welcome in particular any colleagues from GG&C today, because I am aware that there have been some issues with some of the invitations going out to access this particular WebEx. So we're most grateful to see that people from GG&C have been able to join us today. So as mentioned by our host, all of the lines are currently on mute, and we will do that until the presentations from our three presenters today have finished. But we will open all the phone lines to allow participation in some open question and answers with the presenters once that all has finished. But as always, we want to make sure that everybody is engaged as possible while the presentations are going on. So we will encourage everybody to use the chat box. And we do ask that when you use the chat box that you select all participants from the drop-down menu, and that will ensure that everybody can see what you're asking or what you're commenting on, and we'll be able to monitor that as the presentations go on. So the all participants is really towards the very bottom of the drop-down list today, and we do encourage you to use that as the presentations go on. So for those who have joined before, it's I guess a bit of a reminder that we've got three key areas in terms of the priorities for SPSP medicines this year, looking at transitions, omissions, and high-risk medicines. And today is absolutely focusing on our middle priority on the screen that you can see around medicine omissions. But you'll see as well how all of these presentations today are actually quite closely linked to the themes around high-risk medicines and transitions. So again, we're really looking forward to the people that have agreed to share their work with us today. Before we do get started, we'd like to make sure we've got some opportunity to engage and get an idea of who we've got with us by identifying who or what profession you really identify yourself as. So I'm just wondering if you could open the poll, please, in terms of asking the particular question of which of the following professions best describes you, either medical, nursing, pharmacy, or other. And if you are identifying as something that's considered as other, please let us know in the chat box. So that poll, as you can see, is open now. And if we could close that poll, that would be fantastic. So while we're waiting for the poll results to come up, I mentioned before that we've got a number of presenters today, and the presenters are coming from three boards that we've identified through our board visits in the last 12 to 18 months around work that's been focused on trying to improve medication omissions. And it's fair to say this is not meant to be a comprehensive list by any means, but these are three boards that we've been in contact with and they've agreed to share their work today. And it's great to see too, we have a mix yet again of people that have joined us today, representing all of the medical, nursing and pharmacy professions, and plus a few others, which includes ourselves, I think, here in the room today, which is absolutely fantastic. So while we move on, we're going to hear from colleagues from NHS Fife, Grampian and Lothian, and again talking about potentially varied ways of how they've approached trying to reduce medication omissions. And I'd like to particularly welcome also colleagues from working in Excellence in Care, just to say before we do progress that we are working with three boards in Excellence in Care to test further this whole agenda of trying to improve medication administration omissions. So if you are here under a hat of Excellence in Care, you are most welcome. It's fantastic that you've been able to join us today. So without further ado, I'd like to actually introduce Pam Thorne and going to ask her to let us hear all of the fantastic work that's been going on in Grampian. Pam, it's over to you.
Hello, everyone. Today I'm going to talk about the work we've been doing trying to reduce the number of missed doses in a mental health setting. So first, some background. I'm a pharmacist. I'm based at an 18-ward psychiatric hospital in Aberdeen, and our inpatients tend to have longer admissions than in the acute sector, with several weeks or months being the usual time spent with us. And most patients are up and dressed during the day and able to leave the ward at nurse's discretion, and we still use paper prescription and administration charts. So we started with a pilot looking at doses of medicines prescribed regularly, including charts for warfarin and diabetic drugs, and medications prescribed as one-offs. And we looked for the previous 7 days at all the patients on an adult admission ward. And we noted the total number of doses prescribed, and for each patient where a dose was missed, we noted the drug, the time, the date, and the reason given for the medication being omitted. So looking at the results, the highest percentage we picked up were missed because the patient had refused. So that's the red section at the bottom. The next largest section was blanks. This is where there's a blank in the admission record where no code was given, and it was unclear if the dose had actually been given and not signed for, or if the dose was missed and then the reason not given. Other reasons for missed doses were being withheld for procedure like ECT and then not given on return, or the patient was asleep, or the medication was out of stock. So looking at the results of the pilot, my first test of change was the decision to ignore the refused doses, because I wanted to look at avoidable missed doses. So I actually targeted the blanks with no code given and medicine being out of stock, because we'd seen a lot of datexes where medicine out of stock was the reason that doses had been omitted. So this is an example of the completed template that I was using for the data collection. I completed a baseline data collection on 4 of our adult admission wards, gave feedback on the results to the ward manager, and then repeated the data collection 2 months later. And then I handed over to the nurses on the ward to continue doing the data collection for their ward each month. And from the data gathered, we could see how many patients had actually missed a dose, what the medicines were that were missed, and if several consecutive doses of the same medicine was missed, and also the time of day and the day of week, and the reason code for the dose being omitted, or if no code was given. As part of raising awareness of the omitted doses, I did a poster for a quality event, and this is the graph that we had on the poster. The baseline was done in the March, and the second column is the October, and it's a cumulative result for all the 4 wards. And as you can see, the red section, which is the number of no codes or blanks, reduced between those 2 dates from 124 in the baseline down to 20 in the October data collection. And as part of the feedback to each ward on the results of the data collection, I did a summary of the number of patients affected, the reasons, and I did run charts showing the total missed doses, which is the blue line, the number of no codes, which is the red line, and the out of stocks, which is the green line, and as well as feedback to the individual wards. And to encourage a bit of competition every few months, an update was sent to all the ward managers showing the run charts for all 4 wards and including any learning points and sharing strategies the wards had found helpful to reduce the doses missed. The wards did put in different strategies to help reduce the number of doses missed. For example, one ward had a daily checklist of patients which showed when doses were due, and this was then ticked off when the dose had been given. And another ward were actually naming and shaming nurses when blanks were discovered by writing the name of the nurse on the whiteboard in the ward office. And most of our wards now use an individual patient tray drug trolley. So when ordering new medicines, putting the initial of the patient against the order made it clear who the medicine was ordered for, so it could be put straight away in the patient's tray on receipt. And using these trolleys has also meant patient's own medication can be used on admission, so that also has helped to reduce doses being missed. I then decided to go ahead and do some data collection on our 4 old age wards. So that was 2 assessment wards and 2 dementia wards. And this time I did a baseline and repeat data collection along with the ward manager or the deputy before handing over to the nurses to continue. And doing it together, a pharmacist and a nurse, we found was very beneficial. This meant that we could discuss the missed doses we found as we went along. The nurses knew the individual circumstances of the patient, and we could discuss whether the medicine was a high-risk medicine for that individual patient. And where doses were regularly being missed because of a patient not being available, whether a past medicine could be arranged, for example, if the patient was going to the day hospital for planned visits or a reason like that. My second test of change after we've done several data collections was not counting all the prescribed doses for all the patients on the ward, because I found that this was the most time-consuming part of doing the data collection, and the actual small number of missed doses meant that using percentages wasn't giving much information. The total prescribed doses for 7 days for a ward of 18 to 26 patients ranged from about 800 to 1,600. And we had situations where the number of missed doses actually fell, but the percentage of missed doses increased. So looking at some learning points. So systems-based learning points. Targeting good recording on the administration record so that there's no blank administration boxes. Good ordering systems for medicines in place so there's less out of stock. Nurses knowing how to get medication if the pharmacy is closed, so overnight or at weekends. Knowing about the emergency drug cupboard, using the on-call pharmacist. And also good communication between the prescriber and the nurse. So if a prescription is unclear or if a new medicine is prescribed, it can be ordered promptly if it's not stocked in the ward. And also good communication between pharmacy and the ward. So if there's a delay in being able to supply medicine, alternative medicine could be considered. And then looking at it from a patient-centred point of view, reacting and preventing further doses being missed for an individual patient. So awareness of the nursing staff, is this a high-risk medicine for this patient? Would a change of dose or timing of the medicine help prevent doses being missed? So for example, if a patient is regularly asleep, missing a morning medicine round, moving the morning medicine round to lunchtime may work well. But alternatively, reviewing the patient's medication to see if there are alerting or sedating medications being prescribed that could be adjusted to adjust the timing or the dose of the medicine could actually resolve the problem. And whether supplying past medicine for a planned absence of even a few hours would be a good choice, or a one-off supply could be written to be given on return to prevent a dose being missed for a patient having medication withheld for a procedure or for a plasma level to be taken. To recap, awareness that there is a problem is the beginning of the solution. You may not be aware of the blanks until you look for them. And an individual patient's case can raise awareness better than statistics. and a ward putting in its own strategies to help reduce missed doses is likely to work better than something that's suggested from outside. So that completes my presentation.
Thank you, Pam, very much. I really appreciate you being able to share the work you've done in the mental health ward setting. And you can see in the chat box there's quite a few questions already coming through, which is absolutely fantastic. And we'll make sure that we get to those at the end of the other two presentations. But thank you very much. So can I ask if you wouldn't mind passing the ball on to Jin, and I'll introduce Jin. And Jin, you can let us know a little bit more about yourself as you start your presentation. Thank you very much.
Thank you, David. Hello, everyone. My name is Jin, and I'm a clinical pharmacist at the Royal Infirmary in Edinburgh. I work predominantly in the renal and vascular ward, but I've taken out information mainly for the renal ward because that's where the project started and all the ideas came from, just to narrow down our intervention. So firstly, I'd like to highlight that this is very much a multidisciplinary team effort. So just to give you a little bit of a background as to why we decided to make an intervention for reducing missed doses on the ward. And this is because from my daily cardiac review, I've noted an increased frequency in missed doses, especially due to medication unavailability. And we actually had an adverse event associated with a missed medicine, a missed phenobarbital. So the patient had missed 3 doses of that, and it resulted in a seizure. So this happened in the renal ward for a respiratory patient who was boarding with us. So on the back of that, the clinical nurse manager, the charge nurses, myself, and the consultants took this very much to heart and thought, you know, we really needed intervention to prevent missed doses. So I've targeted this intervention for missed doses due to medication unavailability. We thought it'd be easier to target one area and then try to look for new ideas for other reasons for missed doses. So as part of our multidisciplinary team, we formed a little working group with an interest in missed medicines, and we designed a simple workflow accompanied by a critical medicines list, of which I'll go through after this slide. And the rollout of this intervention was accompanied by a chain of awareness campaign and some events which I will go into further detail as well. So as you can see here on your screen, this is our workflow which we used and introduced to the renal ward. So we call this the SEED approach, and it's all part of the SEED campaign. We were trying to look for like a catchy acronym so we'd all remember what it is and what we'd use it for. So firstly, we encouraged nursing staff to search thoroughly in ward stock cupboards if something is not available. And once they've exhausted the local supply, we encourage them to evaluate really what type of medication that you're about to administer. In the previous event related to the anti-epileptic, we found that the nurses involved in that situation didn't actually know what phenobarbital was. So very important for them to understand what medication they're actually giving. And that'll also help them to assess whether or not this is a critical medicine and what actions can be taken. So the next recommended step is, if it's urgent, we would encourage them to escalate the missed dose to medical staff. This is also one of the key missing steps. After discussing with medical staff, we noticed that missed doses are not always escalated to them. Although they're all meant to look at the drug charts during ward rounds, sometimes with time constraints, they don't always notice that a dose had been missed. So all missed doses events really should be escalated to nursing staff, to medical staff. So if there's a suitable alternative, we can suggest, or they can suggest of appropriate actions to be taken. And then out of our service, we would suggest that they contact us like a site management bleep who has access to a database who will tell them how to access the medicine, or the on-call pharmacist if required, and also what they can do during office hours. Best approach would be to contact your ward pharmacist, and the ward pharmacist would be able to advise them what to do. Next, we move on to the next step would be to encourage everyone to document the incident, because with the previous adverse event as well, we found that sometimes even when they note that there are doses missed, they need to do something or they have done something, it's not documented in the patient's notes at all, so there is no documentation for an audit trail. So this is absolutely important. And as Pam had pointed out previously, not documenting what had been done on the Cardex is also a problem. So documentation is absolutely important with this. So we introduced this workflow over a course of 6 weeks on the ward. We mentioned this workflow on a daily basis. We kept talking about seed, everybody, take the seed approach. And all of our nurses sort of had it in their head and, right, we are doing this, we need to focus on this. And I found that even after that 6 weeks period, everybody still remembers it, and it's catchy, they remember it, and they know what to do with it. So next, you can see here, this workflow was accompanied by a list of critical medicines. This list is compiled by members of the working group as well. With a multidisciplinary team input, we've managed to come up with quite a generic list of medicines to try to cover most critical lists that we can. We understand that this list might not be exhaustive, and different specialist areas like oncology may have slightly different preferences that they would like to change on the list. But for our area, we thought this is a generic enough list that we would be able to guide our nursing staff on the different types of medicines and what medicines they should never miss. And as part of the awareness campaign as well, we gave out pocket leaflets where everybody went away who came to the awareness session every day in the morning on the wards, got away with a list that's like a little leaflet which they can take away and keep with them. It serves as a reminder of the whole project, as well as a little reference list of critical medicines. So you can see here a summary of the results. So before the intervention, I've assessed it based on the proportion of patients with one or more missed doses due to medication unavailability. That's about over 40% of patients with one or more missed doses. And after the intervention, it went down to 25%, and we've actually recently repeated it, and it's gone down to 15%. So we've managed to sustain and maintain the trend of reducing medicines unavailability, reducing missed doses based on medication unavailability. I'd also like to highlight here that the proportion of patients with consecutive missed doses have reduced from over 20% to about 8%, showing that people are taking actions, ordering drugs promptly and just looking for them and not having repeated missed doses, which we have highlighted in our awareness campaign that is absolutely necessary to take an action when you have a missed dose. I'd also like to highlight that we've gone for proportion of patients with one or more missed doses instead of total number of doses missed, because as you're all aware of, patients in the renal ward have lots of medicines, and the number of missed doses may not accurately represent how much or how frequent the patient is missing a dose. And as you would all guess, the patients with more medicines are probably more likely to have more missed doses. So we thought let's audit it based on the fact that the patient has one or more missed doses. So we thought that would be a better representation. I also looked at critical medicines based on the critical medicines list, and also the perceived severity of the adverse events associated with the missed doses. I'd like to point out that during the time of data collection, none of the patients who missed the dose, including the critical medicines, had an adverse event. So members of the multidisciplinary group made an assessment, and it's myself and one of the consultants and the senior charge nurse, and we thought, let's assess all cases here and make a judgment on how severe the adverse event would be if it should happen. So for a matter of sustaining this work in the renal ward, we have continued to publicize the SEED workflow and running the SEED campaign on the ward. And we've noticed that this had not only increased the number of people asking about medicines when it's not available, but really just thinking about medicines and making medication a priority. And a recommendation we would like to make to other areas is to certainly involve members of the multidisciplinary team, because everybody has their specialist ideas. We're all trained slightly differently, so when we all come together, put our heads together, we'll be able to carry out an intervention which should be more successful. So this workflow is going to be tested in other specialist areas as well. It's now being adapted into the pre-registration pharmacists project, supported by one of the principal pharmacists in the Education and Research Department, Caroline Suter, who is supporting the pre-regis to try and run the same intervention in other wards like acute medicine and medicines of the elderly as well. And for a more general type intervention is to really encourage people to think of medicines more often and incorporate the missed doses awareness in the nursing curriculum. So I've been in touch with one of our nurses who's gone away to do a facilitating teaching post in Napier University to try and teach the importance of reducing missed doses to young nurses. And of course, we have ward level teaching for all new staff, both medical and nursing. All right, so that's all for me. Thank you very much.
And thank you very much. And again, it's just fantastic to have probably a little bit of a different perspective in a renal unit in terms of the work that you've undertaken compared to what's been undertaken in Grampian in the mental health unit. It's absolutely fantastic. And you can see too in the chat box there's questions coming through as well. So it will definitely pick those up after we've heard from our final presenter. So it's my pleasure to introduce Joanne. And Joanne, I can see you've got the ball, so if you wouldn't mind introducing yourself, and we'd love to hear about the work that you've been doing.
Thank you, David. Hi, everybody. I'm Joanne Bellasini. I'm the one-stop dispensing project nurse at the Victoria Hospital here in Kirkcaldy. My colleague Gillian Malone unfortunately couldn't make it today, but we're here to tell you about the work that we've done so far in NHS 5 regarding omitted medicines. So the focus on missed doses at Victoria Hospital started back in November 2015, where we started to test an audit tool. We then confirmed the appropriateness of the audit. This particular audit showed out of 72 cardexes, 44 had inappropriate missed doses. The result of this audit was then fed back to nursing teams at our first Friday meeting that we held. Teams were asked to think of innovative ways to reduce incidences of omitted medicines. We then implemented the missed dose audit tool into our planned care surgical wards. The percentage of the monthly omitted medicines was then reported and a bar graph was produced for the head of nursing. Following that, we then worked in collaboration with David at the Scottish Patient Safety Programme to test and feedback on a new reporting tool and the driver diagram for omitted medicines. So where we are now, in our planned care wards, so our surgical wards, we now have the new reporting tool in use. This reporting tool then has various graphs generated, so each area can use a graph which is most meaningful to them to drive improvement in their area. We're reporting only on inappropriate missed doses due to blank spaces and medicines not available. However, we've decided to continue to use our current audit tool, which focuses on all reasons for omitted medicines, so not to lose opportunity for any other learning, for any other reason for the omitted medicines. So patient nil by mouth, for example. Our reporting tool is held in our local T drive, so each senior charge nurse can access each other's results, and the senior nursing team can also tap into that and look at the results as well. So what else we've done, we've moved into our emergency care directorate now. So into our medical wards, we shared our planned cares experience and learning with the head of nursing and senior charge nurses. They've also started to collect data as well, but they're now using an audit tool that focuses only on inappropriate missed doses due to blank spaces and medicines not available. And they also have the reporting tool now on their local T drive also. So there's been a couple of areas in the hospital that have done some innovative work to reduce missed doses, in particular Ward 53 here. So back in January 2016, after the presentation on missed doses, we began a cardiac sweep. So initially all 24 cardexes on the ward were reviewed daily. It's now completed twice weekly. It did show initially there was room for improvement, so it did show there was blank spaces, there was some inappropriate coding, and there was some medicines not given because the drug wasn't available. It generated discussion and learning with nursing staff involved in the admission on the day the admission occurred. We also had improved communication with medical staff following the cardiac sweep as well. The medical staff would quite often put a box around the intended dose and write review above it, but the medicine never got reviewed. So it was making sure the nursing staff had that conversation with the medical staff to improve the omitted medicine for that reason. The results of the cardiac sweep were then communicated on the ward safety brief at each shift change, and there then became a change in the culture on the ward, so medicines were taken seriously. The nurses took pride in making sure that there was no blank spaces. There was some challenges to introducing the cardiac sweep, so there were times when the ward was just too busy and it couldn't be done. Because it tended to be done during the day, sometimes we missed admissions that occurred on the night shift, capturing them and having that discussion with the night shift. However, to overcome that, we did put it on the safety brief, so the night shift were aware of any issues that occurred. We also found we had peri-op admissions, so when a patient came back to the theatre post-operatively, it looked like the patient had missed their medicine. However, they were actually in theatre, so it was making sure the nurses coded cardiacs appropriately. So although the patient wasn't available to take their medicine, it was making sure that that was documented on the cardiacs. So here's a new reporting tool. So this is the percentage of monthly omitted medicines for Ward 53 from November last year. So it sustains a good results there. There has been a couple of spikes, and that was attributed to new members of staff joining the team. So when the senior charge nurse saw that spike, she then made sure that as new members of staff joined the team, that she made sure that they were aware of the purpose of the cardiac sweep and missed dose audit as well. We've also been doing some work in Admissions Unit 2 here. So in Admissions Unit 2, we had staff nurse who took ownership of promoting and raising awareness of prevention of missed doses as part of our clinical leadership programme. We commenced and continue to audit at least 20 cardiacs per month. The staff were then asked their preference and how the data should be shared. Following some medicine-related incidents, which were mainly down to medicine reconciliation errors, the senior charge nurse increased their sample size. There was a high incidence of medicines not available in the admission unit with our patients who were bringing in their multi-compliance aids. So this actually led to a policy change. So we took that back to the chief pharmacist, and our multi-compliance aids policy now states as long as the medicine in the NOMAD is prescribed exactly on the cardex and in the same time frame, we can actually use it. So we're not preventing missed doses because we don't have the medicine available. The missed dose audit is undertaken weekly to determine the number of admissions in real time, which allows real opportunity for discussion and learning. The unit has a huddle every morning at about 11 o'clock, and the questions asked, have you any omitted medicines today? So this allows an opportunity for discussion and an assurance that the nurse in charge is aware of any issues. Again, there was culture changes on the unit as well, both staff and patients. So patients have been encouraged to bring in their own medicines recently as well, which has helped with our missed doses. This is how the staff preferred the data to be shared. So this is in their clean utility. This is their main drug cupboard. So we have all the graphs available. So medicines available not given due to not being available, or blank space data. So the nurses are seeing it as they're going into that cupboard. Here is the percentage of monthly omitted medicines for the admissions unit. So a lot of the reasons were because the drugs weren't available, so this led to reviews of their stock list as well. Again, some of the spikes there, it was just because we increased the sample size because we recognised there were some issues and learning opportunities. So recently as well, we've had some patient involvement to help prevent missed doses. So back in November last year, we launched our Bring Your Own Medicines campaign. We engaged with the Scottish Ambulance Service, we attended GP forums, we displayed posters in acute and community hospitals, GP surgeries, pharmacy, and on social media. Information on bringing own medicines into hospitals included at pre-assessment clinics and on pre-admission letters, and our posters on the left of the screen there. And we do have on it that it helps to ensure that you could have the right medicine at the right time. So just this week we have relaunched the campaign. We now, as well as the above, we now have posters on NHS 5 vans, stickers on community pharmacy bags. We're going to produce a video. I'm not too sure who's going to star in that. And we also have, as you come into the hospital, some pull-up banners that are right at the revolving doors. So they're very eye-catching. So we thought that our key points for sharing was to have good communication to ensure staff know the how, why and what you're doing. Involve as many members in the team as possible to drive improvement, and reflect on the impact of the learning and experience gained. So we put that in because myself and Gillian, when we were asked to do this presentation, we did wonder, gosh, what have we done? And it wasn't until we sat down and done the presentation, we realised the improvements that have been made because of some of the work that we have been doing. Some areas we would like to learn from others are any novel ways or ideas to engage staff, capturing other reasons for admitted medicines. So are we still looking at all reasons for admitted medicines or just blank spaces and medicines not available? And has electronic prescribing and medicine administration helped with omitted medicines? And thank you very much. That's my presentation over.
Joanne, thank you very, very much. And you'll see as well, I'm not sure if you've been able to monitor the chat box while you present. However, there's been a lot of comments and a lot of positive feedback from all of the presentations that have been shared today, and a lot of questions as well. And I'm quite happy to say that we've actually got a good amount of time for questions now. What we will ask is for the lines to be open to allow for some discussion. But can I ask that if you are in a noisy area and you don't intend to ask a question, please try and either put your phone back onto mute or just trying to minimize the amount of noise that may come across. So again, would you mind opening all of the lines, please?
And at this time, all lines are now open.
Thank you very, very much. So I have noted a couple of questions down, and I will go to some named individuals who have asked the questions on the chat box to see if they'd be happy to pose their questions. And if not, I will pose them to the presenters themselves. But Catherine, Tully, can I go to you first? Because I think you've asked a question in a couple of the presentations. And I think the first one was to Pam around the potential reasons behind the biggest reduction in no codes happening in the ward. Is that correct?
Yes, that is.
Yeah. So, sorry, I've now asked your question, haven't I? But,
yeah.
So, Pam, are you able to answer the question in terms of, I think you did show a chart that had a very significant drop in the no codes on the charts. Do you have any particular change ideas or things that you think had the biggest impact?
I think just actually being aware of the blanks made the biggest impact. Showing just the number of blanks that there were, just raising that awareness on the ward.
So the awareness, I think, has been raised in all three presentations around engaging people, so I think that's a really good point. One of the other comments and questions that was made is really around the range of change ideas that you listed, Pam, and I was personally curious about the impact of what you described, I think, a bit tongue-in-cheek as the naming and shaming approach. What kind of impact did that have in terms of the culture and awareness of the staff in the ward?
I think it meant that the nurses were self-checking that they hadn't missed anywhere and they weren't leaving any blanks, because they were aware that if they did, their name would be on the board. So,
wow. Okay, that's interesting. Catherine, you did ask another question around patients' own medicines to gin, so I'll actually let you ask that one.
Thank you. Yeah, it was just to find out if your hospital does use patients' own drugs and if that would have had any impact on your flow chart that you described.
Yes, we do use patients' own medicines, but as we've seen in the discussions here, that a lot of the time patients don't bring their medicines in. Sometimes in the non-critical medicines, which we don't stock at all in the hospitals, we do frequently ask their relatives to try and bring their own medicines in. That is really the quickest fix to get their own medicines.
Mm-hmm. Thank you.
Thanks.
There was a theme coming through in some of the discussion in the chat box around two different terms, but the idea of identifying medicines that are critical or high-risk medicines. So Alison Mackie, I think you had a question to Pam in the first place around that particular approach.
Hi, yeah, I was just wondering what categorisation system has been used to assign risk.
Don't really understand what you're asking.
So if we go back, and if I can just pull up your slides again, I think you were talking about the concept of reducing omissions with patients who are perhaps on high-risk medicines, or the risk associated with omissions, and if there was a potential system that you used to identify or categorise those.
It was more around the nurses themselves being aware of whether a particular medicine was high risk for that patient. Where you possibly have a medicine, an anti-epileptic medicine that's being used as a mood stabilizer, it may not be such a high risk as if it's being used for a patient with epilepsy.
Right.
Around how urgent, a patient's insulin, that's obviously a high-risk medicine. They need to have that medicine at that medicine round. They can't wait. And so whether another medicine, it's having the nurses understand about the medicine and whether that's high risk for that patient. So like one of the groups were talking about phenobarbital, and the nurse didn't know what that was. So it's around knowledge for the nursing and whether it's actually high risk patient.
Thanks, Pam, and I think that's a useful point to make, and I think it's almost an appreciation of how we use language to potentially mean some similar types of themes. So we are probably looking at something that would also almost be identified as a critical medicine in the work that's been presented through Lothian and the SEED work and the list of those medicines that were deemed critical. And I think so that's really an important kind of understanding to have. So thank you for that. There was a couple of requests as we go through the chat box around a request to share some of the resource, and it was particularly, I think Ruth, you're interested in learning a little bit more about the audit tool that Joanne had referred to. And we'd be more than happy to share any of the tools that have been tested and developed. I know that we've published on the SPSP Medicines webpage all the resource that FIFE had been using, and indeed we can share the things that we're testing as part of the ongoing work as well. So is there anything else, Ruth, that you wanted to comment on that? I know I'm stealing your thunder in terms of just reading out what you've asked.
No, that was fine. It was just to compare it to the tool that we use, just to make sure we're not that we're using something that has been proven with good results elsewhere would be very useful. Thank you.
No, that's great. Thanks, Ruth. So we'll endeavour to get that to you. So thank you very much for that. So can I open the floor now? There are a lot of comments rather than questions going on. I think it's fair to say there's been a lot of positive comment and comments on the fact that it's a fantastic result in the improvement work that's been done. The idea of policy change to actually use patients' own medicines is worth exploring, and comments around the use of patients' own meds and being brought to hospital could be a potential national campaign. So all those comments I think are very welcomed, and we thank you for those. Can I ask now, just if there are others that haven't used the chat box, if you have any questions for our presenters?
David, hi, this is Arvind here. Hello?
Hello.
I have used the chat box, but I'm really keen to ask two questions. I'm curious to know, of the different methods that were used in different wards, was there one that was associated with better outcomes? Did having a checklist trump naming and shaming, or was it the other way around?
The checklist seemed to work for the ward that was using it. The patients were quite mobile and were always around at the time of the medicine round, so keeping track of who'd had the medicine, who hadn't, that seemed to work for that situation. So
different wards and different things might have worked.
Yeah.
Other question, looking at the data in terms of total numbers of errors, and in fact at one point you said that there was a reduction in total number of errors, but perhaps an increase in the proportion of errors over a period of time, and that raises a question that David and I had struggled with in the past. What is a good measure of missed doses? I see that you chose to present it as total number of missed doses, but for different wards, and I don't know what the baseline is, how many patients, etc., are there. What did you think? What would work better?
I think that probably looking at the total number of missed doses. If the number goes up, then you've got more of a problem. I mean, if you're looking at it as a percentage of something, then that can affect the size of the problem. You know, certainly when we looked at it as a percentage of the number of those prescribed, because that varies so much, it meant that the percentage that you ended up with wasn't really representative of what was happening.
So when you have different wards, and I see that both your projects and John's projects, you were sharing the data between wards and perhaps getting wards to compete with each other or enthuse each other. If the baselines are different, then surely it'll be difficult to interpret the data?
Certainly the four adult wards had a similar number of patients on the wards. Those wards have between 20 and 25 patients at any one time, depending on how full. But that can vary. Some patients could be on lots and lots of medicines. Other patients might be on a weekly depot, and that's the only medicine they're on. So, you know, from that point of view, you're never going to be comparing exactly like, but similar with similar.
Arvind, I think you've asked a really good question. I'd just be keen, just in the interest of time, perhaps to get Jin to reflect on which way of reporting you think has the most impact, and then maybe Joanne's final reflections on that question. So, Jin, do you have a particular, sorry.
Yeah, sorry. So basically, we decided to go on percentage of patients sort of affected, so percentage of patients with one or more missed doses, because concurrently in my study as well, it's showed that the number of missed doses is closely associated with the number of prescriptions that the patients have, and different types of patients have different number of prescriptions, which then affects the number of missed doses if you just looked at the number of missed doses on its own. And this might be unique to sort of, but I think for more complex patients with chronic conditions like chronic kidney disease, they have lots of medicines in general, and because they have lots of medicines and perhaps more frequently in a day, the number of missed doses in total might not show the scale of the problem. So we thought just try to make it sort of more representative and more generic to see how many patients are actually affected by missed doses, so you can extrapolate that more in other settings.
Brilliant.
Yeah.
So, no, thank you for that. I'm sorry to cut you off, but I'm just conscious of time to make sure Joanne has an opportunity to. Joanne, what about you, from your reflection so far? What do you think has been the most engaging way to report this particular issue?
Sorry, I just missed the last bit there, David. I couldn't quite pick it up.
So just asking if you've got any reflections so far about what way of measuring the omitted medicines data has the most impact for you locally at the moment?
So the feedback from the senior charge nurses who are now using the new reporting tool has been really positive. They find it really straightforward. They like how they've got various graphs that they can use. So the orthopaedic ward had an issue with blank spaces. So they were able to print that chart off, put it up in the ward so that the nurses could see what they needed to improve on.
Yeah. And thank you for that. So I guess that actually places us quite well to sort of give a quick summary in terms of where we're working to nationally as this being a priority across the program. So we've heard today from 3 boards, as we've mentioned, Grampian, Lothian and Fife. But we're also working and collaborating with our partners with the Excellence in Care Framework, and we're now testing the reporting tool that NHS Fife have been helping us develop in GG&C, Orkney and Western Isles, particularly looking at the reasons for omissions being blank spaces and medicines being not available in the paper environment. And I think, as Joanne's described, we've actually developed a toolkit that can produce a range of different reports, because we're wanting to get that feedback around which way of reporting data is going to have the most impact. Is it the percentage of patients on the ward? Is it by reporting the total number of missed doses that have been identified that month? Or is it the rate that potentially might provide assurance but may not necessarily drive improvement if it's continuously at a low rate? So that's something that we're really testing at the moment with our colleagues as part of the Excellence in Care Framework. So that's just to give you an overview of what's happening in the paper environment. And I think Joanne mentioned too, there's an interest to learn about the impact of HEPMA, and we are working at the moment with Ayrshire and Arran, Dumfries and Galloway and Forth Valley to explore further what omitted medicines means for an electronic administration environment. The systems that surround an electronic versus a paper system might be the same, but the way things are recorded and what systems are in place to improve documentation probably, and we do know, has an impact on what actually happens in practice. So we're working with them to see how we might be able to have an agenda and an improvement program around omitted medicines in the electronic environment. So that's a really quick whistle-stop tour, and Arvin's rightly pointing out here, it sounds like different measurements may work best in different places, and that's why we're absolutely keen to have a range of measures available for testing and getting the feedback around which has the most impact on where you work. So that's a really, really good discussion to be having. So before we do finish at the top of the hour for 4 o'clock, I do want to just confirm in terms of the plans for the next 3 months for our WebEx series before we thank our speakers. We do have November WebEx, where we'll be hearing from our colleagues in the mental health team and here at the Scottish Patient Safety Program, where they've been testing and developing a handy guide for service users regarding the side effects of clozapine. So that's something, again, that fits quite well within our high-risk medicines priority area, and I do know that a number of people have identified clozapine as a medicine of interest, particularly in areas that don't normally prescribe and administer clozapine on a day-to-day basis. You'll notice in December we're being very generous to everyone, I think, including presenters, and taking a break for Christmas. But in January we're going to be hearing from colleagues from Norway who are going to be really sharing some really interesting work around patients in the home on high-risk medicines, which they're really calling their virtual and also talking about some of the work that they've been doing around transitions of care in Norway. So that will be in January. But before we do go on, can I just pass on my thanks yet again to Joanne, Jen and Pam for sharing their work today. It's been a really, really good overview of three very different approaches on the same topic of medicines and missions. We do hope that you've enjoyed it and you can share the recording once it's available on our website with colleagues who weren't able to join today. I just wanted to highlight the fact that our website address has changed. For those who used to going to spsp.scot, we're now ihub.scot. But we are redirecting everyone to our new website. So please do go there, and we do hope to meet with you again at 3 o'clock on the 16th of November to hear about the clozapine work. Thank you all very much.